This is designed to broaden your knowledge of surgery topics, but it's not designed to make you a surgeon. Okay? Like I said, I will talk to you about some surgical procedures, some critical parts of the procedures, but I'm not teaching you to be surgeons. Okay? That's one of the #1 things that I the last few semesters, even not me teaching, but the last few semesters, have been a critical thing. They're like, oh, you didn't teach us any of the procedures. There's too much to learn if we're going to do that in the weeks that we have. Okay? That's not my goal. Bold, underlined, highlighted, whatever those things are in the PowerPoints, I would pay attention to those specific topics. Okay? I will try to do that for all of them. I'm still updating the rest of them. So either will be tested or it's an extremely important concept for phase 2. Okay? No. I apologize. Hopefully this weekend, since it's a 4-day weekend, I'll get more. But like I said, ARC took precedence. I'm trying to keep this, your program accredited. All right, these are course of learning objectives. Do I need to read them? Do I ever need to read them?
No, ma'am.
Fantastic. All right, so surgery, you have the syllabus, okay? The biggest thing that's different on your syllabus is that your books, it'll say Decker. We're not using Decker, okay? You have your current diagnosis and therapy for surgery. This is on Stimson, okay? This is the main book I am teaching out of, okay? If you want, unfortunately this is not on Stimson, I'm trying to get it onto Stimson. Surgical recall is a good, pearl. Everybody understand the word pearl? The clinical pearls. The 1 pages, 2 pages, maybe a couple pages per diagnosis. Surgical recall is very good. Okay? I will try not to test from this unless it is in both tests. Or both text. Okay? Your main source is the current. Cool? Alright. We're reinforcing the PANTS blueprint. So everybody have heard of the PANTS blueprint. Okay? That list of topics that there is no surgery blueprint, which kind of sucks. But if you go through the surgery or the NCCPA blueprint, you'll find that in EM, family medicine, derm, GI, there's concepts and diagnoses that we cover in surgery. Okay? You've already had GI, and you're in an EM this semester. A lot of the topics overlap. Okay, so some of this will be review, some of it will be new. I'll have slides, notes, test reviews, case studies kind of come up. I don't make the test reviews mandatory, but you do get a lot out of them if you come. Okay? Like I said, our labs, we have the IV, the suture, the scrub, and then the HEM lab. Those will be scattered throughout the semester. Those are very fun. And then we have 3 50-point questions. 3 tests that are 50-point questions each. Okay? Alright, objectives. Alright. Let's see. So, surgery. Being a surgeon. Management of surgical disorders. What does it require? Kind of an art, kind of, list of technical skills, but you also have to understand the differential diagnoses and their treatments. You also have to have a genuine empathy, right? When you have someone who's in needing a surgery, this is a big deal. It's not just a cough. It's not just a cold. These are, if they have to go to surgery, it could be life-altering, okay? So showing some empathy and having that level of knowledge of technical skills and understanding of differential diagnoses and their treatments, because you don't want to cut on the wrong diagnosis. Alright? That would be bad. Okay? And it's one of the most difficult decisions that a surgeon makes is to whether to cut or not. Okay? Do we wait? Do we watch? Or does the benefits outweigh the risks? And is it life or death? Right? It's one of the most difficult decisions that surgeons and us as team members have to help make. Okay? Alright, so before we actually do a surgery, okay, unless it's emergent, which even emergent cases, we still do a tiny pre-op exam. These are mainly for elective, urgent cases. We have to make sure it's safe to do so, right? It's not just, oh, well, you know, they have an appy, they're safe to do so. Are they old? Are they frail? Are they malnourished? Right? Is it already perforated and now it's just an abscess? We can't even put, you know, we can't even close up that tear in the bowel, right? So is it safe to do so? Are they healthy enough for the surgery? How do we do that? We complete a complete history and physical. HPI sample, a complete head-to-toe physical exam if needed, okay? When we get more into the urgent/emergent cases, we do more physical or like a focused exam, but we'll get into that. And then assessment and plan. Really, we're trying to identify comorbidities that the patient may already know they have, or that they may not know they have, that could potentially put their life at risk if we put them under general anesthesia. You know, again, risk versus benefits. Are they actually going to survive the surgery that we are about to put them under? If they're not, then what can we do in order to maximize the patient's functionality or maximize the patient's health in order to actually get them through the surgery that they need to survive? Okay? Sometimes it's a teeter-totter. Okay? Sometimes we can't, but sometimes we still try. So with comorbidities, we'll talk about cardiovascular risk. We'll talk about pulmonary conditions, any bleeding disorders. What's their functional level? Can they actually walk to their mailbox? Can they walk up a flight of stairs? Okay? Is their COPD or CHF so bad that they can't even walk 5 feet? Okay? And then anesthesia risk. Have they had any issues? Have their families had any issues? And then, again, like I said, I'm going to keep going back to this. Surgeon's risk versus benefits. It's a discussion. Okay? If the surgeon says, yes, this patient needs surgery, is that the end? The patient goes to surgery. No, right? You still have to get their consent. You can't just cut on somebody that's battery, right? So you have to get their consent. Well, what if that patient is unconscious? What if they're a minor? Okay, informed consent with their medical power of attorney, their family member, whoever it is, their parent. Very, very important. Okay, the surgeon, even though they make a decision to do something, if they don't get that approval, can't really do anything. So then we have to switch gears and figure out what to do next. Okay, so 2 main goals of pre-op valves. Prior to surgery, we don't want to find out that they have a comorbid, my dyslexia sucks, so I may mispronounce stuff throughout the semester. Their comorbidities, thank you. We don't want to know that they have a history of bleeding disorders during the case, right? We don't want to know that they have an asthma or a lung disorder after they're already intubated, right? So we want to maximize that patient's health. If their glucose is 500, we might need to postpone their surgery to bring it back down to a normal level so that they can tolerate the surgery. Okay? So there's things that, you know, like I said, these are 2 main goals of pre-op. We want to find out what comorbidities they have so that we can maximize their health to lower their risk and actually increase the rate of them making it through that surgery. And then anticipate and try to avoid any, so peri-op is before surgery, intra-op is during surgery, and post-op is post-surgery. Okay? We want to minimize those complications. If we achieve the first goal, to maximize their health, we exponentially decrease the chance of number 2 from happening. Or no, we increase the chance of number 2 from happening because we want to anticipate, we want to avoid. Right? Okay. So, the history. Okay, all of you have taken med history. All of this is, you know, your 4th semester. You know, you've taken clin skills, you've taken clin core, at least one of them, right? You're going to work on your history skills a little bit more this semester. But you have to gain that patient's confidence. Right? If you go into that patient's room and you are kind of like all over the place and you don't really know what the surgery is and you don't feel confident, the patient's going to pick up on that and they're not going to trust you, and they may not tell you what the actual answer is. They may just tell you answers what they think you want to hear, right? So seeing that patient as a person and not just a diagnosis is extremely important, okay? Demonstrating concern and empathy. If you're trying to get a history from a family member, right, you still have to talk about that patient as a person. You're trying to get that family to consent. So if you just talk in all military or medical jargon and they don't understand, they're just going to agree and they may not actually understand the risks and benefits. Make sense? Yeah? Most of the time it's formally structured. The only time it's really not is when it's an emergent case. The patient is dying in front of you. Okay? Even then, we still have a formal structure. It's just abbreviated. Things to avoid. There are things to avoid to limit discrepancy and errors. Like I was just saying. So, enthusiastic novice, ask leading or closed-ended questions. You only ask yes-no questions, you're only going to get yes-no answers. But if you really want to know, like, more in-depth, ask open-ended questions. They're good at talk. You're going to get the little old lady who's there for colonoscopy, and she's just going to talk, and she's going to start from the very beginning of her life, right? Sometimes you have to try to wrangle them and talk to, get them back to where you want them. But sometimes if it is someone who's really scared, like it's a cancer diagnosis, or this is the first time that they've had surgery, they're 18 years old, they're adults, right? The first time they're actually taking control of their health, it's going to be scary, right? So they may only answer what you want them, they think you want to know, right? Or they may answer in a way that's like, they don't want to show that embarrassing thing, right? They're bleeding in their stools, okay? They have hemorrhoids, they have rectal pain, right? It hurts to sit. Sometimes they're going to be too embarrassed to actually say that stuff out loud. You really have to try to elicit them to give you that information. A lot of times what I say is, I know this is going to be like feeling like you're telling me too much information, like TMI, but the grosser you are in terms of what you tell me, the more likely I'm going to be able to help you. Tell me what your diarrhea looks like, smells like, what the consistency is. Tell me what your stools are. Are you pooping every two weeks? Or are you pooping 6 times a day and it's mucousy and bloody? The more information you give me, the better I'm going to be able to help you. A lot of times that kind of gives them the okay, it's okay to be embarrassed. When I go around on the floors and we have post-op patients, do I say flatulence? No. A lot of people don't know what flatulence means, right? I want to know, have you passed gas? Have you farted? And if they say yes, I say that's music to my ears. That means your gut's working. That means you're one step closer to going home. It's okay to say stuff like that, right? But if you do leading closed-ended questions, if you don't have that patient's confidence and that trust, they may not give you the right answers. Does that make sense? Okay. All right. Detective work, inductive breathing, and what we already talked about. We have the facts. Either come in for a specific thing. If they're very confident, they'll say, I'm coming in for hemorrhage, I'm coming in for rectal pain, I'm coming in for constipation, whatever. Sometimes it'll be very vague. Okay, I have abdominal pain. And you then have to ask questions and search for those essential clues in order to lead you to that diagnosis. Okay? A lot of things start with abdominal pain, unfortunately. Okay, so there's a lot of different algorithms you can go down for abdominal pain. And then in terms of common symptoms for surgical conditions, like I just said, abdominal pain. If you don't ask about the blood in the stool, they may not tell you. Okay, they come in with abdominal pain and blood in the stool, that means something. Versus abdominal pain and no blood in the stool, no mucus. Okay, your algorithm changes. All right, HPI. This should not be new. Okay? Obtaining a complete history and physical exam. OBQRST. Okay? Extremely important. Some other things that are not inclusive list, but allergies. I need to know what allergies they have, what allergies to antibiotics. Maybe they're allergic to shellfish. Okay? That'll mean I can't necessarily give them a specific type of contrast. Knowing what that reaction is as well. Okay? If they're allergic to a specific antibiotic and that's the only thing that they are not resistant to, we're probably, and it's only a rash, right, or hives, we can treat the hives and give the antibiotic. So knowing what that reaction is extremely important. Last meal, that is for day of surgery, so these are more emergent and urgent cases. You know, when you're having somebody come in for an elective hernia repair, that the surgery is 2 weeks away or a month away, I don't really care what they ate that day. Does that make sense? Any history of previous intubations, whether it's a endotracheal tube, ET endotracheal tube through the mouth, through the vocal cords, okay? Why do you think that's important? I do ask for participation in this class. Why do you think knowing? Say that one more time? Absolutely. Are they a hard airway? Have they had issues getting intubated in the past? Okay. Older people who had a fused cervical spine, not really going to be able to get that chin lift, right? They're going to be in a harder intubation. Any and all complications that occurred with sedation, whether that's conscious sedation, full general anesthesia. I want to know about it with the patient, if they've ever been sedated or under general anesthesia, but I also want to know family. Why? There's one condition.
Don't have a condition, but like congenital like disorders?
No, has to do with the anesthesia. Have you guys heard of malignant hyperthermia before? Yeah, right? Normally runs in families. So if one person in their family has had a bad intubation or bad sedation and it caused that, then anesthesia will most likely have been in order, like already ready in order if that happens. Okay? And then bleeding disorders. Again, patient and family. As a patient, this may be their first surgery. Okay? But if their family member has had any other like bleeding disorders, they didn't clot right, or they clotted too much, we'll get into that a little bit more, but knowing that history is extremely important. Review of systems. Very important. Okay? Normally, in focused exams, right, you only ask a few things about the systems that are kind of associated with what you think is going on. If you're seeing somebody for a complete history physical for like an elective surgery, your surgeon will want you to have that complete list of review of systems. Okay? Because if they say something that triggers, say like, yeah, I've had palpitations before, but they've never had a cardiac workup before, that surgeon's going to want to have that cardiac workup before that surgery, or before we can proceed to surgery. Okay, so going through that complete review of systems is extremely important to a surgeon. Again, when we get to emergent cases, right, life over risk, okay, at that point, we don't really care. We'll deal with it as it comes. Okay, we still want to know if they can tell us. If their family member is there, they can tell us some things. But if they're unconscious because they're bleeding out in their belly, we're just going to take them to surgery. Right? We'll deal with it as it comes. Okay? But for those elective cases, a complete review of systems is extremely important. Functional capacity. Are they obese? Are they cachectic? Are they anorexic? Are they malnourished? Again, can they walk up a flight of stairs without getting super winded? Why do you think that matters?
Perfusion during downtime?
Can help kind of guide you to any risk stratification. Absolutely. Like if they're frail, malnourished, and we do a huge, 3-hour, 4, even 10-hour surgery on them, and they're already malnourished, Do you think they're gonna do well post-op?
No.
Probably not. We're gonna have to put some things in place. If it's an emergent case, we're gonna have to put some things in place in order to get them to functional capacity, or we postpone their surgery until we can bump them up a little bit with their nutritional status. Okay. All right. So we kind of went through the normal H&P. Okay. The next few slides, or actually the rest of the PowerPoint, is specific things on like pain, GI, more specific stuff on what surgeons and surgery PAs want to know when we talk about HPIs. Okay. So first one is pain. Pain is the most common surgical pain or surgical symptom that is brought to us. Okay. Location is extremely important, but I also want to know how rapid of the onset is it? Okay? Is it rapid? Is it gradual? Is it chronic? Is it waxing and waning? Meaning, does it come and go? Okay? Character. Is it sharp, dull, crampy, stabbing, like an ice pick, hot poker? All right? Everything changes, and my diagnosis will change depending on what the character is. Does it radiate anywhere? Okay? If it radiates to the shoulder, I'm thinking more gallbladder. If it radiates to the middle of the back, it may be pancreas or it may be aortic. Okay? So depending on where it radiates will help guide your differential. So severe that it can't be relieved by medication, you still ask, you know, especially if it's like GERD, something like that. Tums help, the Motrin help, does Motrin make it worse? So knowing if it can or cannot be relieved by medication, how long does it be relieved by medication? Okay, say they have the epigastric pain, that burning pain, they eat, it gets better 2-3 hours and then that pain comes back. Or they eat and that pain gets worse. Okay, that tells me 2 different types of ulcers. We'll go through that later on this semester. Okay, any classic associations? Like I said, right shoulder pain, you have gallbladder. Middle of the back, between the scapula, could be aortic, could be pancreas. If it's right lower quadrant, it may be appendix. If it's right or left lower quadrant, it may be diverticulitis. Okay, location is extremely important. How the patient reacts to their pain. Okay, you're going to see this a lot more in phase 2. We call it the cell phone sign. Okay, you roll up into a room because you've been consulted from the surgery service for abdominal pain. The patient tells the ER provider, my pain is 12 out of 10. It's excruciating pain. You walk into their room thinking you're going to be seeing somebody who's full on tears, crying, you know, can't sit still or can only sit still because movement hurts, but they're sitting there on their phone. Do you think their pain is 12 out of 10? Probably not. Right? If they're able to concentrate and play on their phone, either their pain tolerance is super, super high, which has occurred, or that level may not be exactly, you know, what it actually is. Okay? The hardest thing about pain is that it's in relation, like that 0 to 10, 10 being the worst pain you've ever felt. That's the patient's ever felt. Okay? If they've never really experienced a broken femur, they probably don't know what that level of 10 is. That makes sense? Alright? Okay. Alright, changes in GI system. As someone, I tend to talk a lot. So whoever wants to be the volunteer to tell me when you guys want to break, that would be great. Okay, so changes in GI system. Vomiting. Okay, extremely important to surgeons. They want to know what's happening. Okay, how often, how frequent, is there blood in there? Is it digested food? Is it undigested food? Okay. Changes in bowel habits. Okay, often this is a common complaint that people think is often of no significance. Okay, slow changes in bowel habits. Okay, so if they started off with normal bowels and then, you know, 6 months to a year later, they're having like pencil thin stools. They may just think, oh, well, maybe my diet's changed. Maybe I'm having different, like, may not really associate that with the significance of that. Okay? going from normal color to gray charcoal or grayish clay-like stools. Okay, you get pancreatic issues. Okay, tarry black stools. Okay, melanoma, or hematochezia. Everybody remember what hematochezia is? Blood in the stool, but it's bright red blood in the stool, right? Melanoma is dark blood. Another thing is the blood mixed into the stool, okay? Or is it just on the sides? Could mean the difference between just hemorrhoids versus they have an actual GI bleed, an upper GI bleed, and now it's getting mixed into the stool, okay? Hematitis, everybody remember what hematitis is?
Blood.
Throwing up blood, yep, is that ever good?
No.
No, never good. All right. So bleeding from any orifice, okay, mouth, anus, bleeding from any orifice is never good. It always needs a workup. Okay. Most common error is to assume that it's hemorrhoids. If you send somebody from your primary care clinic for hemorrhoids, because they're having changes in their bowel habits, bleeding with their bowel movements, and you don't have a digital rectal exam documented, probably may get an angiogram. Okay? You have to see what it is, right? Because what if you do a digital rectal exam and they actually have a palpable mass in their rectal orifice, or like right inside their anal verge? Right? That's way different than hemorrhoids. Okay, so having a documented DRE is extremely important. All right, importance of family and past medical history. We've already kind of talked about this a little bit. So family history, polyposis of the colon. You guys have all had GI. Remember what this is?
Polyps.
Massive amounts of polyps, right? This is a genetic disorder. They have millions of polyps within their colon. Okay. Do they have a history of that? History of diabetes, chronic pancreatitis, okay? Other endocrine abnormalities, cancers, past history, again, just illuminates obscure illness, present illness. Okay, they may not make that association. Okay. Good rule of thumb: people who are well are almost never sick. People who are sick are almost never well. Okay? But people who are sick, you can't just thread it to new symptoms. Okay? You have that one patient who chronically comes in and it's just vague symptoms. They're just like malingering. You feel like they're just malingering. You got to take them serious every single time, or else you're going to miss something. And that goes for anything, not just surgery. Right? Acute nutritional deficiencies, fluid electrolyte losses. Big one is serum sodium. We'll talk about electrolytes tomorrow. I'm not going to go over them like GU. You guys learned that already with Dr. Evans. But we'll talk a little bit about nutritional deficiencies and in terms of surgery, what that could mean. Okay? And then any medications. So a lot of times you guys will have these patients that will say, I have no medical comorbidities. None. I'm great. And then they give you a list of 10 medications they're on, like Lipitor, lisinopril, metformin. They're like, well, they're all controlled. I don't have any comorbidities because they're all controlled. You still have them, right? So eliciting that medical history from the medications is sometimes, going backwards is sometimes what you have to do. All right, physical exam. It's going to change depending on if you're going from elective to urgent to emergent. Okay? Depends on how quickly we need to take them to the surgery or to the OR. Depends on what we do. Okay? But the biggest thing, cardiovascular, pulmonary, doing abdominal exams, Ballin-Pie score, which we'll talk about, and then neurological. Okay, those are the 5 that you really can't miss. Most of the time, you won't find anything, everything is normal and everything is fine and you can just go on your way. But you're going to find people, you're going to listen to their heart and they have a new murmur. You're going to probably get an echo, have them be seen by a cardiologist before we can get them set up to have that elective surgery, okay? If it's an emergent or urgent surgery, we'll probably still have them do an echo, but bedside echo. You know, there's many, many times where I have somebody who has weird cardiac arrhythmias or weird cardiac whatever. I'll have them come down to the trauma bay and say, hey, I need a bedside echo because we need to take them up to surgery, but, you know, Steve just heard this and we need to get this evaluated right now. What do you think? And they'll tell us and tell anesthesia, you know, kind of, well, it probably should get looked at soon, but they're safe for surgery, okay? We try to find stuff that makes us do a risk stratification, okay? We can't clear surgeries or clear patients for surgeries. That's not what we do. That's not what any consultants are going to do for us, okay? That's a big misnomer. When I was a brand new PA, I did that all the time. Hey, you know, cardiology, I need you to do a risk clearance. I need you to do a surgery clearance, a pre-op clearance for this patient. And they're like, we don't clear patients because that's a liability. That's a big lawsuit waiting to happen. If they say, yep, they're great for surgery, they're clear for surgery, and then they die on the table, that's not good for them, right? So they've come up with risk stratifications, which we'll talk about in just a second, in that it tells us what is their risk of actually making it through the surgery. What is their risk of having an MI during the case, okay? And so knowing if there's any abnormalities that you hear or see or feel or, you know, whatever on your exam, you can't ignore it. You can't ignore murmur. You can't ignore crackles. You can't ignore wheezing. Okay, I've had a patient die that we extubated too soon because he had asthma and pulmonary edema and all sorts of things. Okay, you gotta know. Excuse me. Neurological. This is a big one. Okay, it's okay to have neurological deficits, okay, depending on what they are, but knowing what they are baseline. Okay, I want to know that they've had, or that they, you know, currently went through Bell's palsy. Because if I don't, and I didn't see them until after, you know, like they came in overnight, I'm seeing them in the morning for their morning, exam, and I see that they have a deficit. If I didn't know that they didn't have a deficit, I'm going to say stroke alert, right? I don't know. So knowing what those deficits are, what weaknesses they have prior to the surgery is extremely important. Okay? If they're unconscious, get it from the family member. If they're unconscious and we have no family members, then and they wake up with certain things, then we have to take, you know, precautions as if it is a bad thing until we know otherwise. Okay? Does that make sense? Okay. And then the rest of the exam is symptom driven. Right? If they have leg pain, we do a leg exam. If they have neck pain, we do a neck exam, like that kind of thing, right? Okay. Focused, mainly for urgent emergent cases. Complete, mainly for elective cases. This is not a be-all, you know, thing. This is not definitive. This is not written in stone. This is generalized, okay? For emergent cases, I will most likely do a focused exam. I want to know the very basic pertinent things that's going to kill them if they don't make it through the case, or that I need to know so that they do make it through the case. For focused, or for urgent cases, if we know that it's urgent but they're not going until the morning, like it's an appy that's going in the morning, we're going to give antibiotics throughout the night, we're going to do a full, complete history physical, okay? But if they're at risk of perforating and we're taking them right now, I'm not going to necessarily do a reflex test on their entire body if we're going to surgery within the next day, like, you know, the next 6 hours, right? If I don't have time, certain things can be left off as long as it's not detrimental to the patient. Does that make sense? Okay. A lot of times, just like we're taught, right, general physique. Are they sick? Not sick. Are they obese? Are they skinny mini? Okay, you see that from the door. Okay, when you get to phase 2, you're going to get to a point where you're going to walk into a DR room and be like, that person's not sick. That person is sick. Okay, that's the first thing. Okay, are they sick? Not sick. Critical care, that's the most important thing. Okay, then we look at everything else, right? Maybe we see a huge belly. We got to look for ascites. Okay, maybe they're just fat, but maybe it's ascites and they have liver failure that they didn't really know about. Okay, what if their legs are bilaterally like edematous, right? Maybe they have CHF and they don't know it, or it's not well controlled. Okay, there's certain things. Looking for reasons for special tests necessary for his gratification. So again, you find that weird anomaly. Okay, so EGDs. I'm not going to try to say that word. I will if you want me to. Okay. So I will say there's long words like this that like I practice, and then sometimes it goes well, sometimes it does not. Esophagastroduodenoscopy. It's a hard one. EGD. Okay. So EGDs, right? Are they a trauma patient and we think that they may have an esophagus tear? Okay. You know, we have a wound on their neck and it's bubbling, or it's, you know, not doing well. Stress tests. Okay, they've had an MI in the last 6 months. Probably needs a stress test, maybe, depending on how bad it was. EKGs. They've had a weird heart arrhythmia, palpitations, murmurs. They're sometimes just because of age, if they're over 65, they're most likely going to get an EKG prior to surgery as their normal routine eval. Okay? And then any CT imaging. All dependent on what you find. Okay? Kids, we can find appies with ultrasound. We don't have to expose them to the massive radiation of CT scan. Okay? But if we are like, it's a girl that looks like maybe it could be an ovarian cyst, or it could be something else. It could, you know, like the ultrasound just doesn't really get to where we need to for that diagnosis. We'll do a CT scan. The risks or the benefits outweigh the risks. Okay. Looking at CTs for the belly. Okay. And when I mean belly, anytime I say a CT belly, it is abdominal and pelvis. Okay. Very rarely do we ever just order a abdominal. Okay? If we are following a specific liver thing, but we're following it, we're trending it, and it's like months out, then that may be a case that we only do an abdominal one. Or they have a pelvis fracture. We don't need to do all the radiation of the abdominal, so we just do a pelvis fracture, pelvis CT. It just depends on what it is. But initially, okay, CT, abdomen, pelvis. Okay? Normally for trauma, it's with contrast. Normally for all surgery, other normal general surgery cases, it's with contrast unless they're allergic and unless we're looking for stones, like kidney stones. Okay? Which we'll talk about. Need for additional laboratory tests, x-rays, and then any follow-up exams prior to surgery. Okay? So say you see somebody for their pre-op exam, you notice they have a murmur, you send them to a cardiologist, make sure you have that report, that result from that cardiologist before you schedule them for surgery. The last thing you need is for the day of surgery, your surgeon's like, hey, where'd that echo go? Did they ever do it? And then you find out day of that they never got their echo done. You're like, okay, now we got to push back the surgery even longer. Okay, inconvenient for the surgery, inconvenient for the OR staff, inconvenient for the patient, right? So make sure you, whatever special tests you order, you get back before you actually do the next step. Okay? All right. Special considerations. Other special considerations. Language. Okay? We live in an area that English may not be the primary language. In certain regions, right? I have a lot of Spanish-speaking patients in Yuma. Okay? I had to know that interpreter's number like the back of my hand, okay? Can they actually understand you? I have had patients who spoke Spanish, a little bit of English, and we tried to muddle through it. Is that really fair to the patient?
No.
No. Is it right? Is it ethical? No. If that patient doesn't fully understand what we're trying to tell them, it's not ethical, okay? It's not legal. We need an informed consent. If consent is not just consent, it's informed. Do they actually understand what we're about to do to them, right? We have to cut them open from xiphoid to pubis. That's a big, major surgery, right? They could say no if they don't really understand what's at risk, okay? So, just the patient understand, okay? And that will say language, but also education level, okay? If they didn't finish, elementary school and they just went straight to the workforce because they were so poor, if they can't read or understand at a level, you have to dumb it down for them. And I say that like lovingly, right? You gotta dumb it down for them so that they understand what they're actually consenting to. Okay? Religion. Do they have dietary restrictions? And that's not even just dietary restrictions, right? If they're Muslim, are they going to accept a pig valve? No. You gotta know that. Okay? Jehovah's Witnesses, blood transfusions. I got one to consent my entire career. Okay? That was, he was dying. He didn't want to die. But having those conversations, I had to speak with this chaplain a lot. Right? To try to get on a good playing field. So yeah, what do we do if they don't accept blood transfusions? Depends. Social services, home visits, this is extremely important, okay? Pre-op, right? You don't know that they're living in squalor. They don't have running water. They have to go up 3 flights of stairs in order to get to their apartment. Do they have adequate caregivers? Okay, is this the right place for them to go post-op? I don't know. Probably not. Right? If they're a little old lady and they have a pelvic fracture, they can't go back home if they have to walk up 3 flights of stairs. Okay? Then we already know that we have to get social work involved to try to get them into a nursing facility or a rehab. Okay? So if we know that ahead of time, it'll help them even better. And support groups, those are mainly for, the harder conditions, the harder diseases, the more traumatic. Knowing what social supports and support groups are in your area is extremely important. Okay? All right. Moving on to labs. What do we know, or how do we know what labs to order? Okay? Caveat. Trauma is different. Okay? I have a trauma surgical PA. Rainbow labs are a thing. But in terms of a general surgery patient, okay, there is no such thing as rainbow labs. You must have a reason for why you are ordering such lab. Okay? It could be just as easy as CBC. I want to make sure they're not anemic. Great. Okay? But we're trying to screen for asymptomatic diseases. Okay? You see somebody with a fluid-filled belly, they've never had labs before, we should probably order liver labs. Okay? A CMP. Okay? What's the difference between a BMP and a CMP? Liver. Okay? And some facilities, it's really, really important that when you get to your phase 2 or whenever you get to your duty station as an actual PA, look at what's included in some of these panels. Okay? Because I worked at a place that a CMP didn't have any bilirubin in it. So we had to order a liver enzyme test along with it, which is weird. Okay? But it's very uncommon, but just know that, like, if you keep ordering labs and they don't give you what you want because you think it should be in there, talk to your laboratory and say, hey, I'm trying to get to this lab, how do I get there? Alright. Conditions that contraindicate elective surgery. okay, or that require treatment, okay, diabetes, hypertension, acute kidney injuries, heart failure. Other 10? Okay, 10 minutes. Those that require surgery prior to another surgery, right? Or we talked about, sorry, the conditions that contraindicate surgery. So we have to try to maximize the patient, right? We want to get their blood sugar under control. We may need to get their heart failure under control a little bit better. If they have a kidney issue, we may need to maximize their kidney health before we do surgery. And then disorders that require surgery prior to another surgery, okay? If during our workup we notice that they have hyperparathyroidism or a PO, which is my unicorn. If I find a PO, I'm going to be not happy for the patient, but happy in general. Those require surgery before we take care of that other elective surgery. Okay, those have main like badness that can happen under general anesthetic, and just bad outcomes if we don't take care of them prior to that other elective surgery, right? And then metabolic or septic conditions, if they are really septic, they're really sick, again, trying to maximize that patient health, get them a little bit better before we take them to surgery to try to maximize their outcome of actually surviving that surgery. Sometimes we don't have a choice. Sometimes in order to fix their septic condition, we do have to take them to surgery. But it's always a gamble, okay? So, what labs to consider? We have CBC, we have CMPs. I would not necessarily do a BMP unless it is a very, like, you know, they're doing an open inguinal hernia. We don't need to know what the liver is. But most of the time it's going to be that CMP coax study, so PTT, PT, INR. Okay, a true liver function with really you have to have that total bili and albumin. Okay, and then urinalysis. We want that uromicro. If that shows any weirdness, we may need to get a urine culture. Okay, if they have blood in their urine, you know, microscopic hematuria, we may need to work that up. Sometimes these elderly patients will have a asymptomatic UTI. Sometimes we have to treat that before we actually do the surgery if it's elective. Okay, but it can also show if they're dehydrated, if they're showing protein or glucose. Okay, maybe it's a pregnant patient and she's spilling a lot of protein in her urine. Gotta look for that. Okay, and then glucose, that may be how we actually diagnose somebody with diabetes. And then anybody with childbearing age and HCG. Okay. All right, how do we determine what imaging to order? Okay, we need more information. Okay, when we need more information is when we do imaging. Okay, most of the time the most common one is just a chest X-ray. But it really helps if we really don't know, even with a good history and physical, we really don't know, or you know, between a couple, we need to do a CT of their chest or a CT of their pelvis or something, right? Maybe we need to do a HIDA scan if we need to see if their gallbladder is actually working. Maybe we need to do an ultrasound of the gallbladder. Maybe we need to do to differentiate between some of the mesenteric type injury or type issues. Maybe we need to do an angiography of their intestines to see if it's actually mesenteric ischemia, okay, versus other things. And then directed at specific comorbidities. So people who have coronary artery disease, that's mainly the echo and the stress test. If they have CHF, you probably still get an echo. Okay, if they have COPD, asthma, cystic fibrosis, most likely going to need a BFT, okay, pulmonary function test. So it really depends on what comorbidities we find. Not everybody gets an echo. Not everybody gets a PFT. Just depends on what kind of history you elicit. Okay. All right, we kind of talked about this already. Informed consent, i.e. permission slip. Okay, risk, benefits, alternatives. We have to talk about the alternatives. Okay? If we don't, it's not a true informed consent. Most of the times the alternatives are none. We either do it and we save your life, or we don't and you are okay with being a DNR. Okay? Or we take our chances with just antibiotics and see how it goes down the road, but their complications may be higher. They have to verbalize understanding. Okay? And how we do that is I've just told you the entire procedure and what we are going to do. Tell me what we're doing back to me. If they can explain to you in their own words what we're doing, then they understand what the risks and benefits are and what we're actually going to do. If they can't, you got to start over from the beginning and try to tell them that, so that we can get to that verbal understanding. Some risk, bleeding, infection, injury to surrounding structures, drug reaction, scars, reemergence of whatever we're trying to fix. Okay? Sometimes we do stuff and it just comes right back. Alternatives, observation, medical treatment, or referrals. Writing in your note, all questions were answered. Okay, if you write that, make sure it's true. Okay. And then it's signed by the surgery team. Okay, so either like a surgery PA, the surgeon, the fellow, the resident, the patient, and then a witness that's not on the surgery team. Most of the time is part of the pre-op nursing staff. Okay. If they are unconscious and we cannot find any power medical attorneys or any family members, we can do a double doc. Okay, it means 2 doctors, 2 physicians state that this procedure is imperative for life saving. Okay, if one of them doesn't agree, then we don't get consent. Okay, and then medical power of attorney if the patient is unable to sign. All right, things to consider. This is right before you go into the OR. Remove all jewelry, contacts, dentures. I don't know how many times you've lost dentures. Okay, if they have dentures, give them to the family member. Glasses, rings, jewelry, everything goes to family and or puts in a patient-labeled specimen cup. Team steps prior to operation. If you don't know what that is, it's basically a long list of, going around the room, telling everybody who they are, what case we're going to do that day, what special equipment that the scrub nurses or scrub techs will need, and that kind of thing. Okay. Universal protocol, that's kind of self-explanatory, like right site, right side, right patient, 5 or 6 hours. Okay. And then timeout. Timeout is we are scrubbed in, we are at the patient is asleep. What are we doing? Are we on the right side? Are we on the right patient? Did we get the right antibiotics? All of the things. Okay? And then removal of local hair removal, normally right immediately before, normally with electric clippers. We don't use the razors anymore. It's electric clippers. It actually shows that it has a decreased amount of skin infections. And that's done, they're already asleep, or they're already in twilight being intubated as we start to take care of. Okay? All right. Pre-op conditions, home medications. So if it is critical that the patient needs it, they take it. So thyroid medications, if it's a blood pressure medications that's not lisinopril or an ARS or a ACE, if it's deemed critical, they need to take it. Okay, with a sip of water. We do not give lisinopril. It has a high risk of refractory hypotension during general anesthesia. Okay, we'll resume it after they're done. Okay, the anesthesia team can give them meds to bring down their blood pressure if they come in with a little bit of high blood pressure, but the day of the case, we do not let them take lisinopril. Diuretics, plus or minus, really depends on how much amount of fluids we potentially anticipate that we're going to lose. Okay, if it's a big belly case or if it's a big ortho case, we may tell them to not take it. Okay, because they're going to lose a lot of blood with an ortho case or with an abdominal surgery case. So it just depends. Okay. Pre-op antibiotics, normally given within 1 hour of incision. Okay. If we're just doing skin, we do Hansa or ceftriaxone. If we suspect or know that it is a GI perforation, if there is a hole in the intestines and that has the potential of contamination of fecal material anywhere, we do Cipro and metronidazole. Okay? Normally, if it's an open GI tract type issue, we did a lot of what we call reanastomoses. This is when we take apart the intestine and put it back together, removing that diseased or whatever part, the injured part. Okay? If implantation of a foreign body, most of the time we won't actually implant a foreign body if we can help it, if the area is already contaminated. We'll come back to do that after they're clean. Okay? But sometimes we can't help it, and sometimes we have to. So in that case, we will continue the antibiotics. Okay? Contaminated wounds and immunocompromised patients. Otherwise, we normally discontinue after 24 hours of surgery. They get three doses, and they're basically done. Okay? Unless it's super contaminated, or it depends on the actual case. Okay? Immunocompromised patients is really important. We had a patient. He was a young guy, 20-year-old, I think. I was in Chicago, and he basically got shot 26 times, and surprisingly didn't hit anything major like vital. A lot of belly, so he had a lot of intestinal type wounds. He had a lot of rhinestenosis within his intestines, but it kept leaking, it kept breaking down. Okay, he couldn't heal properly. He was in the hospital for months. Ended up finally getting him to agree to test for HIV. He was HIV positive. No, that's why he was immunocompromised. He wasn't healing because he had an underlying condition that we didn't know about. Okay? Alright, types of wounds. Clean, uninfected. Normal, this is an open hernia. We're not touching bowel. Right? Very easy, very clean, no inflammation. Okay? Respiratory, alimentary, genital, uninfected, urinary tracts are not entered. Okay? This is like skin. Very easy, very, very low contamination. Clean contaminated is when we actually do go into those areas, but it's under controlled conditions. This is not your emergent X-labs. Okay? Contaminated, fresh, open, accidental wounds, gross spillage of the gastrointestinal tract. That is the biggest thing. If it's contaminated, it most likely has fecal material outside where fecal material should be. Okay? And then dirty. These are old traumatic wounds, devitalized tissue, necrotic tissue, current infected, perforated viscera, so perforated bowel. If it keeps coming, it's either going to be contaminated or dirty. Okay. I would know those. I would know these. Be able to differentiate in a question on what type of wound it is. All right. Which of the following operative cases is cefazolin, usually given as an preoperative antibiotic and discontinued within 24 hours postoperatively?
Bad.
Anyway. Who wants A? Anyone about B? C? E? E? A lot of E's. All right. So, this right here, okay, that makes it more than 24 hours. We're not just going to give a cellulite patient 1 day of antibiotics and be like, yep, you're good. All right? So, elective hernia repair. All the rest are going inside the colon or inside the respiratory tract, okay, and then cellulitis. Does that make sense? Yeah? Okay. Moving on. All right, risk stratification and reduction.
That was answer A.
A.
Oh.
Answer is A. Okay? Elective hernia repair, we will discontinue. We will use cefazolin because it's only skin. And we will discontinue within 24 hours because it is a very simple skin procedure. It's open. Or not even open. Even if we do lap or whatever we'll talk about later. But if it's elective, we're most likely giving cefazolin because we're not going inside the GI tract. Okay? Do you guys know what colectomy means? Removal of part of the colon. That means you're going to have to cut into the colon, right? And then thoracic stab wounds with pulmonary, or requiring pulmonary repair, that's inside the thoracic cavity. Most likely, that's especially a stab wound. Are normal stab wounds clean? Is like an attacker going to use a clean, sterile knife to stab somebody? Most of the, right, so most of the time we're gonna give antibiotics for longer periods because of what was used, and plus it's in the pulmonary. And then overlying cellulitis, again, we're not just gonna give antibiotics for one day and then be like, oh, well, you're good. No, you gotta treat for the normal 7 to 14 days. Okay? Now does that make sense? Okay. All right, so risk stratification and reduction. Okay? We're going to talk about the ASA category. This is basically from the Association of Anesthesia, basically helping describe or helping determine our preoperative physical status. Again, talking about tracheal intubations. Have they ever been trached? Have they ever had an ET tube? Have they ever had any type of intubation? When? Any complications? What was it for? Okay? A surgery versus an asthmatic, different. And previous anesthetic reactions, underlying metabolic diseases, current medications, and then we talk about the Apache 2 and Apache 3. These are scoring systems that can predict mortality in critically ill patients. Know that they exist. I don't even think I put them in this slide. Okay. All right. So the ASA classifications for intubation risk. Okay. American Society of Anesthesiologists physical status classification. If you are a PS or an ASA 1, you're a normal, healthy patient. Okay. All of you, normal, healthy patients, you're an ASA 1. Okay. Let's say in ASA 3, a patient with severe systemic disease. Okay. They have uncontrolled diabetes, uncontrolled hypertension. Stage 3 or stage 4 kidney failure, liver failure, okay, severe systemic disease. 6, a declared brain dead patient whose organs are being removed for donor purposes, and an emergency, okay. Emergency is different because we don't care about their functional level at that point. They're going to get intubated either way, okay. So know these. It'll be very easy. If I ask you, it'll be easy to differentiate what I'm talking about. Okay. Determining intubation risk continued. Okay. What does the upper airway look like? Okay. A lot of times this is taken care of by the anesthesia, but it's something that you as PAs should know how to do. Okay. If you're working in an ER, you have to know how to do. Can they be intubated? What's the risk of intubation? Okay. So range of motion of the cervical spine, like I said, if they're fused, they may not, or if they're really old and it's all bony fused, they may not have that range of motion that they need. The thyroid cartilage to mentum distance, okay? How wide can they open their mouth? What's their dentition like? Jaw protrusion, if they have a really bad overbite, okay? And the presence of a beard. Why does the presence of a beard have any input into this? Yeah, mast seals, can you get them pre-oxygenated enough? Is it going to get in the way? Does he have a super huge beard? Is he Santa Claus, right? Is he Santa Claus plus obese? That's going to make a difference, right? So looking at externally facial trauma, I had a guy, actually I wasn't a PA yet, I was an EMT. It was my very first like true traumatic case, and this guy, I do tell a lot of morbid stories, so if you guys don't like it, tell me. I'll try to. But anyway, so he took a shotgun to his chin, and he slipped and it went forward, and it basically took off from his eyebrows down to his chin. And he was still awake. He was still following commands. He was still breathing on his own, sitting up and forward, just blood draining from his face. He was pulling at his jaw, right? Didn't end up making it. As soon as he ended up dying of hypovolemia. But that's important, right? Is there teeth in the airway? Did they hit the dashboard and they just had multiple facial fractures? Do they have a large tongue? I've had that in the ICU. For some reason, he had a really weird side effect and had a huge tongue. We ended up having to trach him. So the evaluate the 333 or 332 rule. Okay, and you put 3 incisors on their teeth, 3 incisors from their chin. Okay, 3 incisors. Yeah, 3 incisors from the tip of their chin to where their neck starts coming down, and then 2 between where the neck starts coming down and their thyroid. Okay? If they meet that, most of the time it's a good indication of being able to open their mouth wide enough and that kind of thing. Okay? Talk about Malachi scores just a second. Obstruction. These are more so for like EM, so epiglottitis, peritonsillar abscess. You only get one shot before their whole, tracheus and post-pharynx swell up. And then neck mobility, like I said. And Malachi score. You have two different types of Malachi score. The most common for you guys, unless you're actively intubating, okay, is this first line. Okay? How, when you look at someone saying ah, okay, you actually have them stick their tongue out and say ah out loud. The difference between their soft palate and the tip of their tongue. So soft palate and the level of their tongue, not the tip, but the level. Okay? If that's open and you can see all the way back, that's a 1. Versus you can't see any of their posterior pharynx because they can't open, they can't say ah, like can't elevate that soft palate high enough. That's a 4. Okay, which one do you think is harder to intubate?
4.
4, right? And then when you actually get to intubate, grade 1 is where you can actually see the vocal cords, you complete both sides, and grade 4 is you don't. Okay? Know this. Not even, I will say you will need it for the test, but you will also need this for phase 2, both EM, when you do surgery, when you're doing trauma, you get to trauma. All this is extremely important. You will look very good if you know what Malachi score is. Okay. So, not necessarily, you only see, that picture kind of makes it look like that, huh? It's 2 and 3 is really subjective, right? So 3 is like you can kind of see a little, you can see back there just a little bit, but 2 is a little bit more, but 1 is like, it's wide open. So you can, I've actually seen somebody with a Malachi, I think I have a 1, where if I open my mouth wide enough and say ah, loud enough, you can actually see my epiglottis. That's a 1. Okay? That's not normal. Okay? Alright. Functional level, know this chart. Okay? So this is, again, for risk stratification. There isn't too many to really know the description. So 1 is healthy with no systemic disorders. Okay? Just like that ASA1, healthy. Okay, versus class 5 is a very morbid patient, isn't expected to survive. That would be like a class 6 of ASA. Okay? So if I were to say their functional level is a class 3, they have systemic disease, but that limits activity, but not incapacitated. So they can walk upstairs, but they have to take a break. Okay? Knowing what their functional level is really going to be important when you do the pre-op exams in phase 2. So I want you to know this chart. All right, cardiovascular risk. Major cause of morbidity and mortality in surgical patients. Okay, number 1 cause of morbidity and mortality in surgical patients, cardiovascular complications. Okay, I have 6 independent predictors of cardiac complications. Okay, history of ischemic heart disease. If you have congestive heart failure, meaning JVD, or you have an S3 Gallop. If you've had cerebral vascular disease, strokes. Okay, CVD is strokes. High risk operation. Okay, that can be a little subjective, but again, like an XLAP, we're doing removing their whole colon. We're going into their chest, close to their heart. Those are high risk operations. Preoperative treatment with insulin. So if we put somebody on insulin drip or sliding scale insulin, like high doses, because their diabetes isn't controlled, we need to optimize them before surgery. And if their preoperative serum creatinine is greater than 2, that is an independent predictor of cardiac complications. So we try to manage these and optimize these as best as possible. We can't, if they've already had a stroke, we can't fix that, but we try to take an account of that, okay? And maybe instead of doing general anesthesia, maybe we do an epidural so where they can't feel their femur being repaired, right? Versus putting under general anesthesia, which increases their risk. Okay? So this is bolded and underlined. Know these 6. Okay? Likelihood of major complications increases depending on the number of risk factors. So if they have ischemic heart disease, congestive heart failure, and they've had a stroke, their risk increases exponentially. Okay? Now, other cardiovascular diseases, hypertension and hyperlipidemia, should be maximized, or should be optimized, but they are not independent predictors. And just because they have these things doesn't mean we need to delay surgery. Okay? If any of the patients come in with these, there's other things we need to do in order to optimize them, and it will delay surgery as minimal as we can. Okay? But if they come in with a pre-op creatinine of 2, we got to figure out why. Is that their baseline? We may need to change antibiotics. We may need to change our approach to optimize the kidneys and not kill them more. Okay? Does this make sense? Okay. All right. So, the MACE. We'll see the MACE on the next slide. Okay, the chart. Okay. This is for non-cardiac surgeries. Okay. If you are a cardiovascular surgery in their clinic, does not apply to them. They have their own risk factors. Okay? Because if you're in the cardiovascular surgery wing, you're already at high risk for cardiac events. Alright? If they're already doing surgery on your heart, you're already at risk. So these are for non-cardiac surgery patients. Okay? The MACE will help predict these risks prior to surgery. Okay? Like I said, I'll go into the chart in a minute, but if you have a MACE score less than 1%, you're at low risk. If you're greater 1%, you have an elevated risk. If there's any suspected history of ischemic heart disease, you should be doing some sort of a stress test. Okay? So MACE. This is the major cardiac risk associated risk index. Okay? So these are the independent risk factors up here, 1 through 6. Okay? The number of risk factors, the higher you are, the more likely you are at risk for having some sort of a cardiac event during surgery or post-op. Okay? So if I tell you, or if the scenario says you have a patient with a MACE of 3 or a MACE of 4, are they at high risk?
Yes.
Yes. Okay? Not going to be any more difficult than that. Okay? But knowing MACE scores, and if it's less than 1, it's low risk. If it's greater than 1, they are at high risk. Okay? All right. All right. Reinfarction after MIs. So generally we try to postpone at least up to 6 months after an MI. Okay, because the risk of having a re-MI is extremely high. But it also depends on the urgency of the operation. Okay. For pulmonary, we want to try to establish the risk factors for post-operative pulmonary complications, PPC. Okay. Advanced age, elevated ASA class, so ASA of 5, right? They're already morbid. Congestive heart failure, functional dependence, they can't walk to their mailbox. Known obstructive, chronic obstructive pulmonary disease. Okay. If you find any of these weird things, decreased breath sounds, wheezing, round eye, you have to decide on what additional things you're going to do. Most of the time it's just a chest x-ray, maybe an ABG, or an arterial blood gas, and a PFT. Okay? Just seeing what their baseline is and if they're actually going to survive the surgery. Okay? Mitigating pulmonary complications. Okay? Really, really important. Pre-op, intra-op, and post-op. Okay? Knowing everything pre-op helps us reduce the risk post-op. Smoking cessation, or at least decreasing asthma control, is super important. Using an IS, this guy right here is an ascending spirometer. Okay, basically it is an inhalation Okay, deep inhalation. You have the patient put their mouth on the blue tube and have them inhale real slow, like they're sucking off, like the slowest drag off a cigarette or really thick milkshake, that kind of thing. And as the higher they get this little plunger up, that means that's the actual capacity of their lungs. Okay, an adult should be above 2,000 milliliters. That's a 2-liter tidal volume. Okay, so the higher they can get, the more lung capacity they have, the better they're going to be post-op. If it's only 500, say they have a full right-sided rib fractures and they can only get to maybe 500, they're going to be at more risk for pneumonia because they can't actually open their airway and like their lungs actually enough to prevent stuff. And then we have deep vein thrombosis. Okay, biggest thing, low risk. Early ambulation, very low risk. If they're low risk, we want to do the sequential compression devices. Okay, have them walk as well as the sequential devices if they can't get out of bed. If they're moderate risk, we give them heparin, sub-Q heparin, or Lovenox. Okay, there are specific doses depending on their body weight and what we need. If they're high risk, we're most likely going to do everything. Okay, if they're a trauma patient, they're not going to be walking for a while, or they're a cancer patient, they're not going to be walking for a while. We're going to do all of the things. All right, important, but FYI, I'm not going to ask you about this slide, but I would read it. Okay. All right, so in terms of timing of procedures, okay, emergency procedures, this says within 6 hours. Okay. I will not test any differently than that, but in real life, it is now or never. Okay? Especially in trauma, we have to get to the OR within 30 minutes. Okay? There are sometimes we go to the OR after they come in with a traumatic arrest. We crack their chest open and we internally shock them, give them internal epi, and we finally get them back. We're not going to wait 6 hours to go up to the OR. Right? We're going to say, hey, OR, we're on our way. Be ready for us, okay? Versus, hey, OR, get ready. We'll come up in 3 hours. If we get them back, we're taking them up directly. Versus, if it's an elective procedure, it can go up to a year. If we need that year to optimize them, then we need that year to optimize them, right? But we keep track of them, and if that say they have an inguinal hernia and it's not strangulated, it's not incarcerated, and we can kind of optimize them. Then we'll take that year to do it. If they come into the ER and it's now strangulated and it's now at risk of perforating or already perforated, well, now it's become emergent. Okay. All right. So know this time frames. Okay. Know the difference between emergent, urgent, time sensitive, and elective. Time sensitive is I don't think I'll ask about time sensitive. It's not really a thing because time sensitive is elective. Okay. But time frames are important. All right, patient undergoing which of the following surgeries would be best evaluated by the MACE? What does MACE do?
Non-cardiac.
Non-cardiac. So which one is non-cardiac? Hip surgery. Okay. Cool. All right. So more pre-op evaluations, more questions to ask. Moving on to the GI tract. Okay. Some of the ASA guidelines are about preoperative fasting. Okay, some recommendations have changed over the last few years. Most of the time, it is refraining from. Most of the time they'll say don't eat or drink anything after midnight for your procedure the next day. They have kind of gone more towards refrain from drinking any clear liquids at least 2 hours beforehand. So they make you stop eating 8 hours, and then you can have like clear liquids, Gatorade, that kind of thing, up to 2 hours. So that way your post OR experience, like your glucose doesn't just drop. Okay. Excuse me. Do they need a bowel prep? Right. That's a great picture of good, excellent, good, fair, poor. Okay. Does your patient need a bowel prep? Are we going into the bowel? Do we have time in order to give a bowel prep? If we do it. The least amount of fecal material we have to deal with in the operating room, the better. All right, hepatic disease. Okay, liver disease increases risk of many, many complications. Okay, the liver does a lot of complex pathology. Okay, pathophys works with coagulopathy. The biggest, meaning if you have liver disorder, you're going to be at risk of increased bleeding because your INR is high. Okay, there is such a thing as hepatorenal syndrome, whereas if your liver goes and your kidney goes, and then you just have badness. Okay. Signs of liver failure. So this picture up top is that spider spider veins. Sorry. And then we have a lovely picture of jaundice. That is pretty much an extreme picture of jaundice. I don't know that I've had anybody come into the ER with like new onset jaundice and they're that yellow. It can happen though. But most of the time you just have that scleral icterus, okay? That's yellowing of the eyes, or the whites of the eyes. Their palms may be yellow, their gums may be yellow, their skin may be starting to be a yellow tinge. So knowing like prolonged bleeding, if you see that, know that prolonged bleeding, you know, you can lead to death. So we need to assess. We need to know that coag panel if they have any history of a hepatic disease. But most of the time you're going to get a coag panel anyway, either way. That's not one that we normally not do. Okay. Assessment of total billy and INR. Okay. If your billy's high, your INR is most likely high. What is INR? And that international ratio thing of, you know, if it's super high, you're more likely to bleed, right? What's the normal range? Less than what? Less than 1? 1.2 maybe? So if you have an INR of 2, 3, you got to figure out, are they warfarin? Are they on a different type of medication, like an anticoagulant that they don't know about? Do they need vitamin K? Do they need FFP? Okay, it depends. Once it's initiated, we can either do it in the bay, or we can actually take it to the OR and have the anesthesiologist do it. Looking for ammonia levels. Okay, so you have somebody who's an alcoholic who had a urgent case. You're following up with them the next day on the floor, and they are just disoriented. They're weird. You know, you kind of have to order those ammonia levels to see if they are encephalopathic. And then we may have to treat with lactulose to try to bring down that ammonia, to try to to bring back that hepatic encephalopathy. Okay. And then there's 2 scoring systems for hepatic disease: the child's Torquette-Pugh score, CTP score, or the MELD score, the model of end-stage liver disease. Okay, so this is the CPT scoring. Okay, the top of the chart are your variables. Okay, depending on how many points they have, depends on how bad they are. Okay, so if they're a MELD or a CPT score of C, right, they're decompensated. They have a lot of issues. Their risk of survival, their rate of survival at 1 and 2 years is pretty low. Okay, that means that they are not compensating at all. That's that person who's strictly yellow. Okay, their liver is failing and or failed. Okay. Not necessarily, but know like that ABC, what those classes are. So if I say this patient has MELD score of 3, they have 63% mortality or higher rate. Okay. All right. Renal disease. Okay, what do we want to know? We want to know their GFR. We want to know their BUN. We want to know their creatinine. Okay. Even if it means that it's not necessarily going to change our surgery plan, but we want to know baselines. Okay. Because if they go through a pretty long case and they bled a lot from a belly wound, okay? And we didn't get that creatinine beforehand, and now they get post-op and their creatinine is 2.5. What does that mean? We don't know. Did they always have kidney disease, or did we cause that from hypovolemia, and did we cause an acute kidney injury from hypovolemia during the case? We don't know. So getting that baseline is super, super important. Okay? Urinalysis, pretty self-explanatory. We'll go over the fractional excretion of sodium tomorrow. Post-op oliguria. Okay? What is oliguria?
Eating less. Very
Not
low urine.
urinating, not producing urine, or very little urine. Sorry, anuric is no urine, oliguria is little urine. Okay, if their urine output significantly decreases post-op, most likely due to hypovolemia, so we treat that with IV fluids. Okay. Be mindful of third spacing, right? CHF. So if you have somebody who's a CHFer, are you going to give them 3 liters?
No.
You're going to be judicial, that's a word you'll see on the test, judicial with fluids, okay? You're not just going to slam fluids into them, okay? Abdominal compartment syndrome, we'll talk about that later. And then if you have so when we talk about the FNA, or FENA, okay? You'll be able to tell whether it's pre-renal, intrarenal, or post-renal, okay? We'll talk about that. But if if you have a post-renal obstruction or post-renal issue plus fever, you always have to suspect urosepsis. Okay, urosepsis until proven otherwise. Okay, all right. From this page, mainly the complications. Okay, kidneys regulate a lot of your electrolytes. Okay. So if you have kidney disease, we really have to watch your potassium, your magnesium, okay, sodium. Shortness of breath, may have pulmonary edema, may have anemia of chronic disease if you have chronic kidney disease, okay? And you all know adjusting meds to not kill the kidneys, right? If they're already having chronic kidney disease, you're not going to give them meds that's going to kill their kidneys more. Okay? Neurological. Like I said, great to know baseline prior to OR. Okay? We may need to do the carotid artery stenosis test, right? That's just listening. Okay, if you hear any weird bruits, maybe you need to get a carotid ultrasound, okay, to see how bad they are. Maybe we need to fix those first before we fix the hernia. Okay? Pre-op positioning, this is really intra-op positioning. It's padding. Okay, neuropraxia is really, really bad, and it's a very preventable condition. Okay, if we're doing a thoracic case and they're on their side, right, if they're not padded correctly, they could have weird neuropraxias or numbness, tingling, that we could have prevented. Loss of motor function is the most common finding. So you're gonna show up to your patient the next day and they're gonna be like, yeah, man, I can't like move my 3 fingers real well. Like it's real numb. We did that. Okay, just from not padding correctly. All right, diabetes. Go ahead. Oh, 6 minutes. All right. If you have diabetic patients, more likely going to have the skin soft tissue infections. Okay, so that's why we optimize them, and they're going to have potential chronic wounds. Okay, whatever we do to them, we must have a plan in case whatever we do to them doesn't heal. Okay. We want their blood glucose level, their goal is less than 180. If they're fasting, we want it less than 140. Okay, most of the time we stop oral diabetic meds like metformin and we put them on a sliding scale. Okay. We try to avoid hypoglycemia, just increases all bunch of complications. Anybody who's at a higher A1C level of greater than 8 normally has a longer stay because we're chronically trying to maximize all of their things. Most of the time we put them on an intravenous drip for perioperative glucose control. If they stay on that, that goes to the ICU. So that's hourly blood sugar tests, hourly tweaking that insulin. Okay, that's not something they do on the floor. All right. Like I said, short-acting sub-Q insulin is normally what we do with the sliding scale. If they are a really bad diabetic, we'll put them on a long scale plus the short-acting. Long-acting plus short-acting, but it really just depends. We do not let them do their own glucose control in the hospital. They shouldn't be doing their own finger sticks. They shouldn't be giving them their own insulin, right? Don't be using the patient's own insulin. Use the hospital supply. Okay? Type 1 diabetics are prone to develop DKA. So most of the time, we give them either 75 to 100% of their normal long-acting insulin dose the day of the case. We may just not give them a short-acting until after. And then people who are chronically hyperglycemic, most of the time they are dehydrated. So we will start glucose, like D5, or as well as starting either IV or sub-Q insulin. So that'll be something that we do a lot. Okay. All right, acute kidney injury. The biggest takeaway from this is that with all of these pathways that you've already, you took endo and junior, right? Yeah, so you already kind of have an idea of all of these things and all the pathways, and you've heard of the hypothalamic pituitary adrenal axis, right? Know that with pain, it stimulates posterior pituitary that releases ADH, decreases urine output, results in a mild AKI, normally resolves in a few days. Okay? And then intravascular volume loss, that means third spacing. That means any fluid that we put into their vasculature, it kind of seeps out of their vasculature and goes into their soft tissues, so they're nice and swollen, they're plump. Okay? You're going to decrease urine output, dilute serum sodium. Okay, so low serum sodium, from water retention because it's all out in there. Remember where water goes, sodium goes? Okay, so if they're super big and puffy from all the food we gave them, they're going to be low on sodium. Okay, and then normally we just watch it really, really carefully. These people are normally in the ICU and it normally resolves a few days post-op. All right, steroids. Not very common, but catching people who have Addison's or Cushing's disease prior to, there is a very, chart's important, but FYI, okay? If you have somebody who has Addison's or mainly Addison's, if they are hypotensive, hyponatremic, and hyperkalemic, they're most likely in an Addisonian crisis. Okay, you remember that from endo? Okay. There's other things we do pre and post-op if we find that, okay? And there's depending on the type of operation, depends on how we actually do the corticosteroid administration to help prevent this crisis, okay? And then thyroid, we try to make sure that they're euthyroid, okay? Prior to surgery, because hyperthyroidism, if that's not controlled, it can cause a thyroid storm. Hypothyroid can cause cardiac failure. Not great. Okay? Alright. Can I go for a couple more minutes? How many slides do I have left?
5.
I think 4, because the last one's just questions. Do you guys mind?
Send it.
Okay. Sorry, I think I talked too much earlier. So bleeding disorders. Biggest thing is if you come in and they have a big joint, like it's mainly a kid, and they don't know they have, hemophilia, right? That's something that you need to be aware of. Deep vein thromboses, if they keep getting clots, maybe they're factor V. Okay, so bleeding disorders, knowing what they are. Medications, knowing if they're on any sort of Plavix or warfarin or any type of anticoagulant, you must stop. But if they've had a cardiac stent or if they are a new stroke patient, then you probably need to talk and have a team meeting, right? Talking with the neurologist, the cardiologist, and the surgeon to say, hey, when is it appropriate to stop if we can stop, okay? That we may have to do surgery with them being on an anticoagulant. If it's going to kill them to come off their anticoagulant, then we have to run those risk benefits. Liver disease, again, PT-INR. So TEG, we'll talk about it in a minute. And then if you come across anybody with a particular rash, knowing what their bleeding time is, their PT, PTT, is really, really important. All right, so TEG, thromboelastogram. Some hospitals have it, some hospitals don't. Okay, just know that it is real-time monitoring of coagulopathic, acutely injured patients. Okay, we can literally, for hospitals that have this, we take their blood, we put this in the machine, and it'll tell us if they're normal, if they're on heparin or warfarin, just depending on the curve that the machine spits out at us. It'll tell us if they're in DIC. It'll tell us how long they're taking to clot, how long they're, like if they're clotting too fast, right? So it'll tell us different things in terms of, you know, what it's seeing in terms of how that patient's blood is reacting, and it'll tell us kind of, okay, they need cryo, or they need FFP, they need platelets, they need TXA, they need something, like, depending on what that bell curve gives us and what it shows, kind of gives us a diagnosis of what that blood is doing. Okay? Not every hospital has this, just know what it does. Okay? So the real-time monitoring of acutely injured patients, really it helps us modify how much blood products we give somebody. Okay? If we are like kind of in a zone of they're still bleeding, do we give FFP or do we need vitamin K, or like what is wrong with their blood's clotting system? We use a TEG in order to kind of guide us and say, okay, no, this is really, they don't have clotting factors. Let's give them FFP or whatever. Okay? Does that make sense? Okay. And then nutrition, really important, imperative for healing and recuperation. Okay? If they are have an albumin less than 3, okay, suggest chronic malnutrition. Now, I think you read or was taught about the fluid albumin. Not the same thing. We can't give them albumin in order to raise this. Okay, it's a different type of albumin. I know that's kind of confusing, but it's a different thing. So the lab value, the serum albumin, cannot be fixed with IV albumin. And we'll talk about that more tomorrow. Okay? And then pre-albumin, if it's less than 16, that shows more acute. Okay? So if we see someone who's cachectic, severely malnourished, and we really want to know like how bad are they, we'll get pre-albumin and their albumin and actually look. And if they are, you know, less than 16 pre-albumin but a high albumin, that means that they're acutely, something's not right, versus if their albumin is really low, they're chronically, something's not right. Make sense? I would know those. Okay? We'll talk about this more tomorrow. We try to correct physiological abnormalities prior to surgery. We'll talk about the fluid resuscitation. We'll talk about correct coagulopathy. We'll talk about correct acid bases, and then repleting electrolytes. Those are our standard normal values. Know these for the test. Know the normals. Okay? If I tell you that the albumin, or I'm sorry, that the magnesium is like 0.5, or hypomagnesia, right? You need to replete. Okay? If their magnesium is 6, they're hypermagnesium, and we need to do stuff in order to fix that. Okay, so just know that those are the lab values. I will try to put them on the test as well, but you should know what normal is, okay. Especially for phase 2. Sound good? All right. Any questions? We made it through our first lecture. Perfect.